Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Muhamad Aly Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is Physician Suicide Prevention, a Call to Action. Muhammad, welcome back to the show.
Thank you very much for having me to talk about this important and ever timely topic about physician suicide prevention and how we can help our colleagues during tough times.
All right. So, for those who didn't get a chance to read your recent article, what's this one about?
So last year, I called attention to this phenomena, suicide, physician suicide, a silent epidemic, and how suicide was affecting a large number of vulnerable physicians, and that the fact that we were losing the equivalent of one medical school class every year, close to 500 physicians suicide a year. This was last year. This was in December 2024. And we are again December 2025. In October, we lost a pillar of the psychiatric community, psychiatrist Nolan Williams, who was a major researcher on depression, anxiety, and transcranial magnetic stimulation. We lost him. His life ended with suicide, quite unfortunate, and he was missed by a lot of his colleagues. But that actually highlighted how this silent epidemic is affecting our fellow physicians and kind of prompted me to write about this again because it does not seem that the epidemic is remitting in any way and call attention to that because depression and anxiety is affecting our colleagues out there and we're not seeing that this thing is backing away and it's we're losing more and more physicians.
So, is the rate of physician suicide as compared to other professions? Talk about the contrast. How much higher is it, and what is it specifically about the medical profession that may contribute to that higher rate in relation to other professions?
It is definitely higher than other professions. We're kind of a little bit ahead of lawyers, a little bit ahead of dentists, and a recent paper, actually just early on this year in May 2025, in JAMA Network, reviewed the cause of death among U.S. medical residents and looked at data between 2015 to 2021. And suicide was the single leading cause of death for medical residents. So it's very interesting that this young population, you see this young population who's going through residency, who just finished medical school, and suicide was the single leading cause of death. Not accidents, not illness, not cancer, suicide. And the highest rates were actually in the first couple of months when they started their residency. So that kind of highlights basically the intensity of the feelings of depression and anxiety and stress that medical residents are facing. And that also goes on and translates into stress and anxiety and depression that they face later on in their professional career, which puts us at a high risk for depression and anxiety and ultimately completed suicide. So I'm just calling attention to that, especially for residents. The new class is starting, as well as other physicians. So it is still ongoing, and we're at a higher rate as physicians.
From your perspective as a psychiatrist, can you speculate on some of the reasons why, especially medical residents who just graduate medical school, are more prone to anxiety and depression? Or what are some specific facets of the medical profession that can lead to anxiety and depression among physicians?
The high pressure that we face on a regular basis, and we're seeing that also there's a higher incidence of pre-existing depression in a lot of new classes of medical students. We're also seeing kind of the demands of the profession kind of accelerating. We're seeing students graduating with high level of debt also that's affecting them. We're seeing kind of the intensity of graduate medical education kind of significantly increasing, even though compared to our time in terms of residency training, the number of hours has significantly been decreased. We never had the 60 or 80-hour rule in our residency days, but we're seeing that that also has contributed to more residents facing more difficulties and not being able to adjust and acclimate to residency training and leading to symptoms of depression and despair and suicide that is reflected in the JAMA paper. So I think that that's why I wrote this paper to kind of bring attention to program directors, to other clinicians, that this is a real phenomena and we need to really be cognizant of that and help fellow residents as well as other fellow physicians.
Physician burnout, moral injury, and suicide, they've been common themes on my site and on this podcast for years now. Do you feel that those in charge of medical school and training and our healthcare entities, do they take this phenomenon seriously? And if so, what are some of the things that you're seeing that they're doing to help mitigate physician suicide?
I think they are hearing about it. They're hearing it. They are trying their best. We are seeing that some programs have started in large health systems where physicians are paired with, especially those that are thought to be affected with burnout or depression, are paired with a peer where they do have a peer check-in. They're asked to be aware and audit their sleep, that they're able to talk to employee assistance program. And we know that also that people feel that the licensure language sometimes is punitive if they come forward with symptoms of depression. In terms of program directors, especially with special focus on the period where the residents are mostly vulnerable, that period of the month one and month two of residency training, and trying to map out the interns or the residents that they feel are at the highest risk. And maybe even we're seeing that sometimes they put attendings on wellness call at night where interns and residents could call that attending, holding protected time, wellness time, people kind of commiserating or talking about the difficulty of residency training. So we're seeing a lot of residency program directors acknowledging that this is a significant issue that they need to address in their classes of intern and among residents, just because they're seeing it happening more often and the statistics are reflecting it.
It sounds like some of these approaches are more reactive in nature. Is there anything that we could do with the profession itself? And I know that there has to be some baseline stress in medicine, but do you feel like there could be some improvements in the profession itself to help mitigate some of the potential causes that may lead to suicide?
I think, and this is why I'm talking about this. I think normalizing this fact that we are humans. I mean, we always portray physicians as superhumans. We
Hmm.
we are there. We can do it no matter what. Surgeons, psychiatrists, internists, ICU doctors, that we are superhumans, that we are there to do it anytime. You can call us 24/7 and we would jump into being able to help and facilitate kind of the wellness of our patients,
Hmm.
but then we forget our own wellness. And so I think that portrayal of physicians, and I think with the COVID pandemic, that accelerated significantly.
Hmm.
That we just were asked to jump in and save this nation who was experiencing this pandemic. And we were asked to work long hours with difficult circumstances in a condition that was unknown. And we were asked to make lots of decisions, death and life decisions. And that really accelerated the burnout and basically increased, I think, what we're seeing right now with increased rates of depression, burnout, and increased rates of suicide in residents as well as in physicians.
In your article, you write sometimes that hospital executives ask for resilience rather than trying to fix the system itself. One option that is suggested is maybe tie their leadership bonuses to the behavioral wellness of the clinician staff, right?
Yes, absolutely. I mean, I think talking about the problem is very, very important. Kind of measuring the wellness, like I said, measuring the wellness, like RVUs. Publish the numbers. Are physicians happy? Are they not happy? What's their wellness? What's the retention rate? What's the burnout rate? What's their access to care? I know, for example, in my area, local hospitals, physicians have very little access to care. They have to go out of their way to be able to access a psychiatrist or a therapist because they also fear that they're going to be reported to the medical staff services. They're going to be reported to the medical board. So they go out of their way. They're secretive. Nobody knows that they're experiencing symptoms of depression and anxiety. For example, colleague Nolan Williams, nobody knows what happened. Nobody knows what he was experiencing, and it's very unfortunate that he was secretive and didn't talk about it, and nobody knew about it, and then all of a sudden his life ended with suicide. Pushing the executives to really acknowledging that this is a problem and that basically they need to be aware of it, they need to be measuring it, they need to talk about physician wellness because we are seeing physicians also exiting medicine. And that's something that you've talked about in your blog also. And it's all burnout and depression and anxiety. And physicians prefer to exit medicine rather than end their life and in response to what they're experiencing.
You wrote in your article, and I like this line, that the cost of prevention is modest, but the cost of loss, the loss of life, is infinite. So I'm going to ask you to put yourself in a position of both a program director and a hospital executive. If we want to value residents and physicians' survival and prevent physician burnout, I want you to tell me one thing that you would do from the perspective of a program director as well as from the perspective of a hospital leader.
From a program director's perspective, I think talking openly about it, day one, July 1st, sitting with the interns and telling them that the program director's door is open, he's available no matter how bad things are, how bad you're feeling despair and depression, and whether you're feeling that you want to end your life because things are so bad. Talking about it from day one, kind of just putting it out there, I think is very, very important. And not a lot of people have the courage to do that because there's the basically there's the issue that people say that if you talk about it, maybe you'll put it in somebody's mind. There's that myth, but actually that's been proven not true. So talking about it day one as a program director, sit down with your interns and say, I'm here for you. No matter how depressed and desperate you are, how you feel, I'm here for you. Your life is valuable to us. We want you to go through your residency and complete your residency, and the country needs you as a physician to help your patients. And you're not good helping your patients if you're not helping yourself. So I think that is the number one that I tell program directors is July 1st, talk to your interns and residents and tell them that help is available and they should not despair. In terms of hospital executives, I think that they only understand the numbers. And so pressure hospital boards and physicians should pressure hospital executives to be measured. Like
Hmm.
RVUs, they be measured by physician wellness. And if physicians are not happy, if physicians are in despair, if physicians are not happy with the system needs to hear it and the system needs to measure it and need to be able to publish those results. And the executives need to be accountable to the hospital board about the fact that physicians are not happy. And we see that sometimes in hospitals where there's an exodus of physicians because they're not happy. And invariably, sometimes it leads to the ouster of the executive of the hospital, and sometimes the hospital just doesn't blink, and they just keep going on and go through another round of physician exodus. But I think hospital boards are hearing about it, communities are hearing about it because they want physicians to be able to continue to work in their community. And this phenomenon of burnout and suicide is affecting our physician community.
We're talking to Muhamad Aly Rifai, psychiatrist, internist, and addiction medicine specialist. Today's Kevin MD article is Physician Suicide Prevention, a Call to Action. Mohammed, let's end with some take home messages that you want to leave with the Kevin MD audience.
To my fellow physicians, I think you need to hold on to each other tight. Ask a colleague to be your sounding board and to be your call-in if you need any support. Support is out there. We want our physicians to return back to wellness. We want our physicians to be safe. We want to be able to reduce this phenomena of physician suicide. We lost Dr. Nolan Williams, and we have lost too many other physicians. So always speak up, always seek help to the physician executives and to hospital executives, build systems that protect physicians, protect people, refuse to normalize preventable death, and refuse to let the next obituary be someone that you know.
Mohammed, as always, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
My pleasure. Thank you.